Hello guys, in our last video we discussed about the airway resistance. Okay, so for respiratory failure, what are all the pathophysiological factors? So in this we just discussed about the airway resistance. In our video we are going to talk about the lung compliance. Okay, what is lung compliance? So lung compliance means it is a measure of the lung ability to expand. Okay, that is the lung going to distance, okay, during inhalation. So that is called the lung compliance, okay, per unit pressure. Okay, so how much volume changing per pressure, okay, that is we can call it as C is equal to change in V by change in P. Okay, volume change divided by volume pressure change. So lung compliance is the degree of lung expansion, okay, that is change in volume per pressure change per unit pressure change. Okay, that is C is equal to change in volume by change in pressure. Okay, if the lung has a good compliance, then it will be normally it going to be expand as normal as possible. Okay, if the lung has a non-compliance, means the lung becomes stiff. Okay, so what is the problem in the compliance? If the compliance is reduced or if something problem means, then we have the problem in work of breathing. Okay, so high amount of work we have to put for the breathing. Okay, so these are all happens in the low compliance. Okay, stiff happening, as well as stiff maximum happens in the non-compliance lung. Okay, and high amount of work is needed for the low compliance patient. If the compliance is low, then change in volume is low, then the lung volume is also reduced, and ventilation is also reduced in the low compliance. Okay, if it is high compliance, that is the change is maximum, then what will be happen? Incomplete exhalation, which means our whole breath in air is not going out. Okay, so that is an incomplete exhalation. So the low compliance is happens in the restrictive lung disease, whereas high compliance is happens in the obstructive lung disease. For example, in emphysema, the lung compliance is high. Okay, and also we measure the lung compliance in two different areas. Okay, static lung compliance and dynamic compliance. Okay, static means when there is no airflow, during that time we are measuring. Okay, dynamic means when the airflow is present. Okay, that time we measure, that is a dynamic. During static it only shows the elastic resistance of the lung, elastic resistance. During dynamic we can notice both elastic as well as airway resistance. Okay, so we can measure these two. During static we can measure only the elastic resistance of the lung. Okay, of the lung, not only the lung, chest wall we can notice. Dynamic we can notice the elastic resistance of the lung and the chest wall as well as the airway resistance. For these two we have a different formulas. Okay, for static compliance the formula is the correct tidal volume divided by the plateau pressure. What is plateau pressure? Okay, we can write this as this. Okay, P flat. Okay, so it is a pressure applied to the alveoli during ventilation. Okay, during ventilation how much pressure we are applying. Okay, so this is we are measured during the end inspiratory pause, which means after inspiration there is no flow of air. On that time we are measuring the plateau pressure. Okay, by this we can understand how much pressure we are applying to the alveoli, that is a plateau pressure. Okay, minus PEEP. PEEP means positive end expiratory pressure. Okay, so pressure maintained in the lung in the end of the exhalation. Okay, after, which means this is the pressure applied after inhalation. Okay, this is after exhalation, that's it. Okay, so the pressure in the after inhalation minus pressure in the after exhalation. So this is during the ventilation process, mechanical ventilation, these two are happen. So by this we can measure the static compliance. Then come to the dynamic compliance. We have the corrected tidal volume divided by so corrected tidal volume means normally the lung has a normal breathing, that is called tidal volume. Okay, corrected tidal volume after the problem, any problem in the respiration happens, after that we are correcting using the ventilator. So that is a corrected tidal volume. Okay, so dynamic compliance means same, we are correcting the tidal volume divided by peak inspiratory pressure minus um, uh, positive and expiratory pressure. Okay, so peak inspiratory pressure means in that time the plateau pressure means after inhalation is done there is no flow, on the time we are measuring the pressure. Okay, peak inspiratory pressure during inspiration we are measuring the pressure. Okay, so here no flow, here there is a flow, that is a difference. Okay, that another all the things are same. Okay, for whom static compliance is reduced? Which patient? Atelectasis, ARDS, tension pneumothorax. Okay, atelectasis is a partial or complete collapse of the lung. Okay, ARDS is a acute respiratory distress syndrome. Okay, life-threatening lung condition. Okay, so fluid build-up in the air sacs. That is in the alveoli there is a fluid. So that is the acute respiratory distress syndrome. Okay, then tension pneumothorax. Pneumothorax is a air becomes trapped in the pleural cavity. Okay, and it also gives the tension to the lung. Okay, so which means it also forces the lung to collapse. Okay, like that. Then obesity and retained secretions. Okay, in these all static compliance is reduced, and in some condition dynamic is also reduced. Okay, like bronchospasm. Okay, kinking of the ET tube, endotracheal tube, kinking. So there is a twist. Okay, inside the tube there is a twist or anything that is happen. So that is a kinking of the endotracheal tube. Then any airway obstruction. So if there is any obstruction in the airway, then that is lead to the dynamic problem. Okay, so there is a flow problem. Okay, so these are all happen. Okay, another thing we are going to talk about the dead space ventilation. Okay, we have both anatomical dead space as well as alveolar dead space, physiological dead space. Okay, anatomical, alveolar and physiological. Okay, three type of dead space we have. Okay, let's discuss about the anatomical dead space. Okay, so anatomical means gas exchange is not happening, but there is a passing, that is conducting is happening. So anatomically it conduct the air, but it does not exchange the gas. Okay, then alveolar dead space. Inside the alveoli, some part will be doing the gas exchange, some part will not doing the gas exchange. Inside the alveoli, not exchange happen. That is the alveolar dead space. Then physiological. Okay, it is both anatomical as well as alveolar. Okay, anatomically it passes the air and it is a part of the alveoli, but it is not exchanging the gas. Okay, so for a normal people the physiological dead space is insignificant, which means we can't able to notice any part that is not doing the gas exchange. Okay, very minimal part is we can notice. Okay, that is also not identified by the us. Okay, but if the person having the lung disease, then we can easily note physiological dead space. So we can notice some part which does not involve in the gas exchange. Okay, so we can notice during ventilation we can notice. After ventilation we can every part inside the lung is doing the gas exchange or not, like that we can identify. So for that we have the formulas and all. Okay, so that is VA is equal to VE minus VD. Okay, so these are all happens. Okay guys, in this video we just discussed about the lung compliance. In our next video we are going to talk about the hypoventilation and vacuum mismatch and intrapulmonary shunting and diffusion defect. Okay, thanks for watching guys. Tata, bye bye.